so that we have for transcription.
Your conference is being recorded.
Great, and thank you for joining us. We have Dr. Eric Ruderman on the phone right now, and as well we have Brett, our medical writer. And the topic today is expert perspectives in rheumatoid arthritis. And Dr. Ruderman, you have a clinical topic update here, and then you have two clinical topic updates and a patient care perspective. Really, I mean, there's not much difference. It's just when we start talking about developing the articles. The angle that we take might be a little bit different. So the clinical topic updates were more interested in emerging information, and the patient care perspectives were a little more interested in conversations you might have with the patient about the topic or with other docs about that topic. So, the first one is optimal use of imaging in RA. So let's get your general thoughts on that, and then I can drill down with a couple of follow-ups if that's okay.
Okay. I mean, the general thoughts are that we have a lot more options for imaging than we ever did before, and in some cases, good data on the value of those, and in some cases, we're not really sure. And I think when you look at them, you have to sort of step back and recognize why we even want to worry about imaging in the first place. And the history of that is simply that, in managing somebody with rheumatoid arthritis, in addition to treating symptoms, we're concerned about, long-term function and long-term impact of disease. And there's a very good correlation between joint damage and structural damage and functional disability down the road. And that in the short term, particularly early in the course of disease, functional issues are driven in many cases by inflammation. The more inflammation, the more difficulty the patients have. You treat the inflammation, you improve the inflammation, and their function improves. But as time goes on and more damage occurs to the joints, particularly in untreated patients or inadequately treated patients, then the damage itself begins to drive the functional deficits. And even if you reduce the inflammation, you're left with those challenges. And so the point of the imaging is to ensure that we're picking up signs of beginning structural damage and addressing it early on, with the idea that ultimately we want to reduce structural damage, not necessarily in and of itself, but because of its implications for function and activities of daily living. Historically, we've always used X-rays, and in fact, the old classification criteria for rheumatoid arthritis used X-ray changes as one of the components of that criteria. When those criteria were updated in 2010, X-rays were taken out, and they were very specifically taken out because you actually want to be able to identify patients with rheumatoid arthritis early and treat them early before the structural damage ensues. And so that's become sort of the goal of imaging, is that you want to identify patients and initiate aggressive therapy when the imaging, at least the radiographic imaging, is normal. Okay, and then you look at imaging over time, and if you begin to see changes, then the issue is, are we treating the patient adequately? If we're treating them to a clinical target, but there are imaging changes that go on, is that an adequate target? The new wrinkle in the last 10 or 15 years has been the advent of other methods for imaging, and that's either MRI or ultrasound. The advantage of those is that you can pick up potential structural changes earlier, which I'll get back to in a second, but they also identify inflammatory changes, which you simply don't really see on X-ray. On X-ray, you may see periarticular osteopenia, which sort of implies inflammation of the joint, but it's not really quantifiable, and it's a very sort of rough guide to what's going on. Whereas with ultrasound and MRI, you can actually identify joints where there is active inflammation and potentially follow that over time. So where people have begun to use these new imaging modalities varies, but there are a lot of potential opportunities. So one is to use them early to identify patients who do in fact have inflammatory arthritis when the diagnosis is unclear, when, clinically it's a bit uncertain. They may have inflammatory symptoms, but exam doesn't really confirm that. You don't see a lot of clinical synovitis. Imaging may identify changes that might, identify someone with early rheumatoid arthritis that's not entirely clear on a purely clinical basis. The other big question early on is whether ultrasound and MRI, by virtue of the fact that they can identify structural changes early, whether that adds an advantage. And that's a subject of a lot of discussion and a lot of disagreement over the years, because on an MRI and an ultrasound, you can see early erosive changes that may not show up on X-ray. The challenge is that not all of them then proceed to X-ray changes. In some cases because they simply don't, in some cases because of therapy. And so it's a little challenging to know whether those kind of structural, early structural changes that you see with those imaging techniques are helpful in what they add to the treatment approach, because treatment is largely driven by clinical outcomes. And from a treat-to-target perspective, the goals are truly clinical goals, not imaging goals. The next question is whether following those imaging parameters over time makes a difference. And so, in the past, if we've had patients on perhaps less aggressive therapy than we have available, and we do follow-up X-rays and we see progressive damage, we may consider changing treatment. That's less of an issue with biologic therapies. As we've moved into the biologic era, there's quite a bit of evidence that certainly for TNF inhibitors and likely for other biologics, that once a patient's on a biologic, there's little progression of radiographic damage. And so the value of doing serial radiographs is much less, because we just don't see the change. And the other problem is that even if we do, it's not clear what treatments we would switch that patient to that would be better. Whereas in the past, if we saw, radiographic damage on a patient, perhaps on hydroxychloroquine, which we don't really use that much first line anymore, we might say, well, now they need a more aggressive disease-modifying drug, or even a patient on methotrexate who had progressive radiographic change, we might say, well, that may be an indication that it's time to switch to a biologic. The addition of new imaging parameters and the challenge there is whether they add value to that sort of ongoing treatment approach. And so, particularly thinking about the sort of push now to a more treat-to-target approach, identifying a goal of therapy and adjusting therapy until you achieve that goal. There have actually been two recent studies that have looked at adding, in one case, MRI and in another ultrasound to a more clinically based treat-to-target approach. And in both cases, they didn't show that the addition of that advanced imaging added very much value above and beyond simply clinical assessment. So it now is unclear. We have these great tools for imaging. They're certainly outstanding at identifying inflammatory arthritis early when we may be clinically uncertain, but the value in their sort of ongoing use in managing a patient is a lot less clear. Finally, I think the one thing that's a proposed value, and it hasn't entirely been demonstrated yet, but it does make some logical sense, is that as we have better and better treatments, we're beginning to think not just about adding or changing therapy to achieve a goal, but now we're thinking about tapering therapy when we've hit that goal. That if we get a patient in remission, is it possible that we can begin to taper therapy either to avoid safety issues or cost in many cases, particularly with biologics. And so then the question is, which patients, if you begin to taper treatment, or in some, potentially even stop treatment, which patients will that be successful in, and which patients will flare, absent what you've been giving them already? And there's some thought that perhaps ultrasound, and there's some early evidence that perhaps ultrasound may help there. That if you have a patient who's in clinical remission, there is some evidence that deep clinical remission, patients whose disease activity scores are really, really low, they do best with tapering and even in some cases with stopping treatment. There's now some evidence, not quite as good, that perhaps ultrasound could be useful in that scenario. That if you have a patient who's clinically in remission and on ultrasound still has active inflammation that you can pick up on ultrasound, so this is not structure but the inflammatory change, that may not be a patient you want to push hard at trying to reduce damage because you have evidence that they have persistent active disease and your concern is that they're going to flare if you begin to back off therapy. On the other hand, if you have a patient who's clinically in remission and on ultrasound is also in remission, you just don't see inflammatory change on ultrasound, you may feel more comfortable being more aggressive about withdrawing or tapering therapy.
Mm-hmm. Great. I think you covered almost everything I was going to ask about. Just two follow-ups,
Sure.
And really they're more, chewing on it, reflecting. The one is, I believe, we spoke